this on your? Do I have to?
Do
I
I
just
go?
put it on?
Yeah, go ahead.
It's not loud.
Go ahead. It's not loud.
No, we're not gonna be able to hear you any louder. It's just
So I shouldn't yell. Okay, everybody, I don't want to keep it too crazy long, but I'm sure it'll be a good half hour. So I posted this PowerPoint on both of your clinical courses, your 736 and 746. Ask questions. And if you want me to go faster through something, you want me to slow down on something, where you're going to find that I do go through when we do our radiology report, and it's those soft tissue. So I'm going to hit that kind of hard so that I get everybody on the same page, and have pulled pictures from your text so that you can go back and read a little bit more about them if you'd like. So the D3 test, if you listen to the D3 board review Wednesday, it was from last year, and it mentioned that the test was in March. It is not. It is next Thursday afternoon, right? 1 to 3, exams off. So you do have two separate exams, D3s, one that's anatomy, exactly what we did in D2 year. So the intraorals, pan, skull, dry bones, just like we did, mirrors what we did in D2 year. And then the interpretation exam, which is both going to be intraorals and of course pans. So back to mirror the radiology report and kind of going through the big sections there. Also D3s, I'm going to give you that quiz for your D4 panoramic comp so that you'll have that paper portion finished. Because once you have finished all the comps in your D3 year, you may begin your D4. So I'm going to give you that written quiz. That helps in the delivery of the real patient panoramic comp. That portion's already done. It's the doing part then with the patients. Okay, so we're going to go through some of that panoramic here, but again, I gave you a myriad of PowerPoints, I know, in your courses, and all of that, of course, is what we had done in that previous course. Good review there. Hey, what you doing? D4, it is just the one exam, so the interpretation, and we are Friday from 8 to 9, correct? Friday, 8 to 9, okay. And then I know you have OD after that. So can I answer any questions about this part? On the computer, other than that panoramic paper, that will be paper, so bring something to write with, of course, but the others are on the computer.
For the D4, does it just fill in the blank and multiple choice?
And that's on that paper I gave you about the test. So you've all had my exams. It's just a little bit more of the same. There are things that are got to come out of your head. You know I am not a word list person, and there is no word list on things. So it's deciding what things are, and we're going to go through some of those interpretation examples here. But yeah, a little bit. There's a few multiple choice, true, false, but it's those fill in the blank type of things, or essay where you're typing, which I think fair. You know, this is going to be your office. This is going to be your life. You're looking at images. There are no ABCDs. There are no arrows pointing to anything. It's you critiquing that entire image. All right, I'm going to stand over here if that's okay, but if you have any questions, holler. So D3, you have these panoramics, the partial and the full. I'm going to use them again. So for anatomy, and again, it's going to be intraoral, this pan, perhaps the large pan, skull, the dry skull, dry mandible. And again, for D4, I'm not going to ask you as it was tested in D3 year, but of course, knowledge is assumed. Any questions? I don't need to go through anything here unless somebody's got some questions. And if then after I finish, if the D3s want me to come back to anatomy a little bit, I will. All right, but if anybody has any questions now, otherwise that frontal view of the skull, and then of course here's the dry mandible. So of course we've been over all of these muscle attachments here. Everybody good on all those muscle attachments? And again, it's just knowing when you look at a panoramic, what all is sitting there that of course is invisible. Can't see all those muscles. Dry skull from the backside. Oh, hey, this is going on its own. I don't like this. Who can stop that? Who knows how to stop this from moving? Who's my person? Who's my computer person? Come on, somebody, come on. Help. It's moving on its own. I don't want it to move on its own. How do you undo this? Okay, nobody's going to help me. I just got to keep going backwards. I don't know how. Okay, skull. So we've seen this. So my D2s have seen all of this, and I am using this again. So knowing, and of course this is our area, is right in here where it is the busiest. So if you have any questions there, and of course looking from behind, we've looked at the inner surface of the mandible, even where the metal is here and the screw. Those are important things down here. And of course, what bone are we on here? Sphenoid bone, right? So there's your sphenoid bone from underneath. Because what do we have? That little pointy guy right here. There's your hamulus. Off which pterygoid plate? Medial. All right, so there's important stuff there. Any questions? And I will come back if you want. So I think you have all of these. This is all the PowerPoint. And again, we've been through this. If anybody has questions, otherwise I'm going to move through some of this anatomy. But this is what you can expect then, the D3s on your exam. What side of the maxilla are we on? There are clues here, right? So find your clues. What is this white line? Floor of the sinus, right? Floor of the sinus. And of course, this is, we all know and love, zygomatic process of maxilla. So the small portion of the hook faces which way? Posterior or anterior? There's the dilemma. Posterior or anterior? Anterior, right? So that makes this which side of the jaw? The left. What else is another hint? What is this? Cornoid, right? You're only going to get the cornoid then because the mouth is opening and the cornoid came forward. Hey, back it up. And the cornoid came forward, so there's another hint for you. Of course, we know the sinus isn't going to take over all of the maxilla because you have a nose. So it's going to leave some bone, typically around that canine, maybe this was first premolar area, that there's typically some bone sitting there. Good? A little bit more anatomy. Holler if you want me to stop and go over something. So it's that posterior, a lot of stuff going on up here that maybe you marry it to the skull then. Lower anterior mandible, of course here's your genial tubercles or mental spine. There's 4 of them, upper 2, lower 2, what attaches. And what do we call this guy in the middle? Your lingual foramen is the hole then in the middle of those tubercles. We good here? You've had this image from me before, so seeing all those lines, and just because the teeth are gone, the lines remain because muscles attach, right? So they never go away. They may get closer together because as the bone resorbs, but they never go away. There you go. Hey, this one, external oblique, right? Internal oblique, also known as mylohyoid line. Here's your cortex. Everybody knows what attaches. Okay. Nobody knows how to make this stop. People on the tape are going to be annoyed. Sorry about that. Carrie, cervical burnout anatomy. We've done that in class. So you've seen this image before, but it holds all the pieces of the puzzle here, doesn't it? So we see some vertical bone loss here, And how do I know? I draw a line from CEJ to CEJ. Is that bone? It should be paralleling, and it's actually going opposite. So yes, a vertical defect here on the distal of 13. I'd say I probably have one here on the distal of 12 also, off of the field. Darkness, so I have a little dark triangle here. Caries, low on my list, right? What's top of my list for this little dark triangle right here? Anatomy, right? Anatomy. You've got, you've got the mesial of the, oh, sorry, that was me that time. Mesial of the MB here, mesial of the palatal here. So that is anatomy. It's just less tooth there, less density, less tooth. Where does burnout happen from what to what? CEJ to the alveolar crest, right? To the bone. That's the only place you call something burnout, is from the CEJ to the crest of the bone. Why? What is burnout? You've all heard me talk about it 100 times. Why does this happen? Because the crown is covered in enamel, big dense enamel, and the rest of the root is covered in bone, right? And that little piece in the middle is just tooth, just what's remaining of the root there. So you've got big, heavy, dense enamel around the crown, and you've got root and bone for the rest of the tooth. Burnout only happens between CEJ and crest of bone when we have it. So here, little darkness here, yeah, little burnout, little bit of anatomy. Do I think there's caries anywhere on these surfaces? No, no caries. No, you don't have burnout in enamel, right? It's the portion of the tooth that has less amount of structure around it, less dense structures around it, okay? All right, caries, everybody good? Class 5s, you see your smiley faces here. Little class 5 caries, whether recurrent, whether occlusal, whether this is a buccal pit or not for sure, but probable recurrent underneath. Bone level's good, right? 1 to 2.5 or so millimeters from CEJ, so the gurus say. External oblique, internal oblique running through there. Computer did that. Periapical, little wide, but is that something to be concerned of, you think? Don't know. Don't know. Might have to test the tooth. Might have to see how far these caries go when you remove the caries. Okay, I think we've all seen this picture. Again, looking at bone levels into the dentin, right? So running up and down the DEJ there, running up and down the DEJ here, mesial of 19, of course, huge here on 21. Another bite wing, moderate. So by definition, mild is incipient enamel only. Moderate has made it to the DEJ. So when we're looking at caries, and here we are a little darker running up the DEJ. So I'd say here we have made it into the dentin. Here we're into the dentin. Here we're into the dentin. We get a little bit shallower here. Maybe this is incipient. Here we're into dentin. Also dentin. Even here, distal of 30, you can see that. So we get that little bit of overlap, but I can still see where the caries are. Bone levels within normal. All right, so periodontal disease, huh? High quality bite wings, best for looking at bone levels. Periapicals, too much vertical angulation. Always have to have bite wings. And you know when you come to me with an emergency and you come to take a periapical, what do I always add on? The bite wing for restorability. So always make sure you're looking at the crown from a bite wing perspective. Yes, we need periapicals, of course, to look at periapical pulpal disease, but you gotta have bite wings to totally, fully assess your caries and your restorability of the tooth. So here I've got, of course, your typical traditional horizontal bite wing, as long as I can then still see bone levels. Computer, starting to pick up little furcation here, I'd say on 31, perhaps 30, even though my bone is up here a little bit darkened at the furcation as it is here. Remember, you can always turn your sensor vertical and get more of what's on each side of it. So you get down that root a little bit further. And remember that periapical technique using the vertical holder. You have a small mouth, a short front to back distance, so much easier for the patient to turn the sensor lengthwise so it's not bumping in and hurting, because they're not so compliant when that sensor's rubbing into the tissues. So turn your sensor, turn it vertical to create a periapical. You may not get as many teeth front to back, but you'll get a good image of what you're looking for. All right, never hurts to do that. Periapicals, of course, we're going to do those in a periodontal series, but you got to remember what vertical angulation does to your diagnostic ability of teeth. Okay, so as you add more and more vertical in a positive or a negative manner, it gets a little bit tougher to look at bone levels. Those who have been in radiology, AI has come. Pearl has come. Her name is Pearl, and she's in radiology on those 4 computers that sit back to back. And as we're in there and we've started using it a little bit with a full mouth series, but I want you to do it first. You pick out the caries first. AI identifies, it tries to do bone levels, it does calculus, it does caries. 100%? No way. Right? No way. It is a tool to be used, perhaps a patient education tool also to show, but I've had images where huge caries and it didn't pick it up. It didn't see it. So, shaker of salt. You've heard that old expression, it's a shaker of salt. It's a tool in the tool belt, but you can now use it back in radiology. In those computers, and I think on the computers at the desks, at the faculty desks, but not the rest of the computers. And if it doesn't have Pearl, you can't see it. If you want to come back and try it, you'll have to come back to radiology and you can apply the AI on our computers back there. Yeah, we tried some yesterday. What did those students think of it? Claire gives a thumbs down. You have to be smarter than the computer. Yeah, I have to be smarter. It may pick up something from a different angle, perhaps your eye didn't catch, and then once you take a look at it, but it doesn't catch everything. It does not. It's a tool. One more periodontal disease, little vertical bone loss here. Well taken periapical. I don't need a bite wing to look at that, but certainly some vertical bone loss here along that tooth. Periapical disease. So from the left, this is from your text, early, mild widening at the apex, right? Pulpal disease, periapical pulpal diagnosis, slight widening. My eyes hardly see it here, but a little widening, so they say, at that apex. Does the tooth have cause? Sure it does, right, to have something going on, but it is subtle. Now, go back to the molar. They were pointing out early here with the arrow, but back here on the molar, sure, that's already blown out into a rarefying osteitis, and again, huge caries, pulpal diagnosis. The middle picture here, also from your text, loss of lamina dura is always, remember what we're looking for, lamina dura and a consistent PDL space. Sometimes I'll still, maybe that PDL widening as this picture might be one of the first things you see, is that the PDL starts to widen out a little bit at the apex, beginning periapical. But here, of course, we're a good rarefying osteitis there also on tooth number 7. And here I've got picture number 30, endo treated, and yep, rarefying, and maybe even I'm going to call that sclerosing. It looks like it's been there a while. and the bone's gotten a little harder around that mesial root here. All that bone is thickened and hardened here. We're also up into the furcation here. Right. Bone levels are okay. They're not great along the sides of the tooth, but definitely you say, yep, I've had a previous endo-treated tooth. Whether this is new or old, we don't know. So whether it's still healing or this is 5 years past and now this is all new, that's objective and some subjective. Patient, you'll learn from patient information. Everybody good on periapical? So periodontal or periapical, all right? This is the one, so who I had yesterday in clinic in the afternoon, this is that gentleman. And so we always, you know me, we take a little straw poll there. Who thinks it's periodontal? Who thinks it's periapical in nature? So tooth number 8 here, and you can see where your bone levels. So do you think this is periodontal bone loss or periapical bone loss? What things are going to hint towards periapical pulpal disease? Root resorption, maybe, right? And I'd say we have a little bit over here, root resorption. But what else is going on in the tooth that's going to lead you to a pulpal? Big caries, right? Or large restoration, previous restoration, crowns, big caries, previous endo, right? All lead you to thinking perhaps a little bit more pulpal diagnosis, right? But this is periodontal in nature. This is periodontal disease on the picture on the left. So tooth number 8, this is periodontal bone loss. Where does periodontal bone loss start? At the crest of the bone. And it can wander all the way up and around, right? Surround the entire root of the tooth. Okay? Picture of periapical tooth number 24. Periodontal or periapical in nature? What say you? Periodontal again, right? Even though, yes, we do have some external apical root resorption. So big kickers here, and there could be a little pulpal, right? So the big kickers, no caries, no restoration, but there could have been trauma that we can't see. So if I can't see a fracture, I don't know trauma either from, of course, this two-dimensional image. So there could have been trauma here, but definitely the bone, yep, we are all the way down around the entire root of the tooth. Of course, we have calculus all over here, and we do have some root resorption. I think its fate is the same, either path you take, right, that it's going to be extracted. But that's where as you start to critique and use those skills of what is the nature of that pathology. Periodontal, periapical, neither. What do you think on the picture on the left? Picture on the left came from your text. Picture on the right was a patient. Picture on the left, what do you think? Do I need to do endo? So again, I run through my same, and of course you're going to have objective tests also. You're going to pulp test. You're going to do electricity. You're going to do hot cold. You're going to do mobility. We don't have any of that here. We're looking at an image. So remember, we're looking at an image. But again, no caries, no restorations. We do have some bone loss here for sure. But I've got this big lucency surrounding probably 3 apices there. Anybody want to take a guess? Come on, somebody. So traumatic bone cyst is totally radiolucent, right? A cyst totally radiolucent. Not in this case. Yes, sir. Is there a, say it again, is there a, What kind of display? Ooh, display. Ooh, dysplasia. Yes. Got to think outside the box. Periapical cemental dysplasia, or you'll see PCOD, so the periapical cemental osseous dysplasia, around 3 root apices. And again, we haven't tested. I know of no other tests. We are looking radiographically. But remember, it is, African American, middle-aged females, but it can be anybody. Outside the box a little bit sometimes, all right? Periapical cemental dysplasia. Same over here. That's what this is also. Periapical cemental dysplasia on both images. Now, this patient has tons of calculus and bone loss. Again, no visible caries, no restorations. Yes, I have a wide PDL, periodontal in nature, on 24, but all of this lucency down here and here was also turned out to be periapical cemental dysplasia. All right, so just get you thinking outside the box a little bit. Everybody good with that? And again, you're going to be doing your testing, so it's not, images do not stand alone. You know that. Images do not stand alone. Okay, a little bit of anomalies on the left side. Amesiadens, you got an extra tooth there. This came from your text. This one's heading north. This one's heading kind of down and towards crown only, no root development. This one has root development all the way down here to the crest and then up. So amesiadens. And you've heard me say, when might you first see it? When that central incisor doesn't drop. One does the big thing to hold up permanence, odontomas. Odontomas also like to hold up permanence. On the right side, what anomaly is going on? Hypercementosis. So big bulbous roots here, normal PDL, normal lamina dura. We've just got extra cementum around them. Here seems isolated, number 4, but I think maybe even the molar here might have a little extra cementum on it. Right? Might make extractions a little more difficult. Got to cut it into pieces. Picture number 1, anomaly. Dens and dente. Number 2, taurodont. Number 3, dilaceration can be anywhere through the root, at the apex most commonly, but it can be anywhere through the root. Everybody good? And just some attrition. Attrition here, and we've got 2 teeth, 2 separate canals, but 2 crowns. Fusion, right? 2 came together as 1. Gemination, 1 splits to 2. Right? Common, I don't know if I've ever seen in an adult or if they've had something extracted along the way, but you'll see it in primary dentitions. All right, panoramic. Anatomy, single reel, double reel, ghost, your 3 lines for alignment. And then what happens when things aren't aligned correctly. All right, you tell me how fast or how slow to move here. All right, so these again came from PowerPoints from the lectures. This came from your text, just simply remembering things that are anatomically on a horizontal line, a plane, are separated because that pan is minus 10 degrees. So coming up from below the jaw, and then it's going to separate things out vertically on your image when in true they were on the same plane. This picture depicted everything is within the confines of the focal trough. Everything will show then in pretty decent order on your image. But when teeth are tilted, we're a big class 2 here. Class 2 here also, but we caught the upper, and of course a class 3 here on D. We're not going to catch everything. All right, some things may be in and out. Same thing when the jaw is rotated, head is rotated, or we're slightly back or slightly forward. That can either be that the teeth have moved off of the bite stick and they can be forward of the groove or back of the groove, or the teeth are perfect in the notch of the bite stick, but the light was placed too far forward, too far back, same results. So it doesn't always happen just because the patient's teeth aren't in the groove. It can happen because of where the light then was placed. This was also in one of your PowerPoints, just a reminder of how much ghosting happens. They placed half of a cadaver skull right side and took the full image, and all of this blurring then is simply because of from that one side of real tissue. And we have gotten used to looking at that pan image, but again, just kind of in the back here, oh yeah, I've got different shadows that come in and out of that image. All right, you know our unit, right? You know what everything is. Number 1 is our Ceph sensor. 2, soft tissue filter for the Ceph or for a PA. Whatever, PA shouldn't be needed, but Ceph, because I've got soft tissue hanging out there by itself, and then I've got hard tissue behind. Number 3 is my source for both techniques, right? Both techniques. I only have one radiation source, and then pan sensor, number 4. Oops. All right, so of the 3 positioning lights, failure to line up which light correctly caused this occlusal plane to be flat. Which light? Oh, I shouldn't have to say another word here. Which light was incorrect? Frankfurt. And where was the chin, up or down here? Up. The chin was up a little bit. That flattened the occlusal plane and probably threw that condyle off the edge. Okay, so chin up flattens. Chin down. All right, so Frankfurt plane again, chin down, too smiley. Then my condyles fear to run off the top. Did they keep their tongue tight to the palate, like stuck with peanut butter? They did not, right? Evidenced by, here's that black airspace rainbow. So what's below the airspace? The tongue. What's above the airspace? Soft and hard palate. Okay, so we got that little airspace running in there. What's going on at this step deformity? Patient moved, because you remember a pan is collected a vertical segment of a time. Starts at the patient's left and builds across the jaw then to the right side. So the patient, if they happen to move, maybe it bumped their shoulder, they moved, and then they came and they settled back down again. Because it also looks like a fracture perhaps, but we have to be sure that it wasn't technique. You know your earrings, right? Not a problem. And of course, ghosting doesn't only happen with earrings, right? There can be other metals, like amalgams, that might create a ghost, because as the beam comes across, it'll smear on the other side. It can, so we do get ghosting with bone then also as that beam comes around. Is that what you? But also then with other metals. So you may get some smearing just simply because of where other metals are. Critique it, chin is way down, we're smiley, so Frankfurt plane was off, but we certainly got big earrings. Center of the image. Ghost of cervical spine. From each side, and then it builds the middle. All right, so ghost of cervical spine from each side. We can't see our cervical spine, it's off, but all of that is ghosting, and we are chin down. Again, we're crazy smiley. We could have positioned the patient a little bit better. What caused the anterior teeth to look so wide? Focal trough, right? Was the patient too far from the sensor or too close to the sensor? So were they too close to the sensor or too far away from the sensor? Too far away, right? They were too far as the sensor made. So that was either that they came off the stick and they were behind it, or they were on the stick but the light was too far forward. And in essence, it placed them too far back from where you told the machine the focal trough was. Here we're too narrow. Wow, this thing moves along here. What caused the anterior teeth to look so narrow? Too close to the sensor. Again, they were either way forward on that bite stick, or teeth were in the groove, but the light was too far back, that then, as a result, the patient was too far forward to where the focal trough was told. Cervical spine encroaching on the mandible. All right, Smiley again, you got that. What happened to my apices? They're out of the focal trough. Right, out of the focal trough. Last light here. Angle, so teeth are overlapped here. Here we're a little bit straighter, a little bit wider here, a little bit narrower. So that, of course, is my mid-sagittal. All right. Good? All right. Got some good ones. So soft tissue. All right, normal. And you've been with me, everybody's been with me assessing the normal here. We're going to look at normal styloid, epiglottis, right? Looks like my cashew, looks like a comma. And his best friend, the hyoid, which is strung across here, but they are best friends, and you find one, you should be able to find the other. Right? Here's the picture from the text. Knowing what soft tissues, I've got soft tissue attaching here, attaching all up and down here. Of course, ligament then, here's my styloid ligament down to the hyoid. Right? It's just a little bit different look here. Carotid plaque. So this came from your text. That lets you good reference to go. They have many things circled here for you. Where does carotid plaque like to run? In front of the vertebra, which is why many times when the vertebrae are gone, I cannot assess for carotid plaque. So they're pointing here. This is carotid plaque. Also here, this has been a while, right? That it's had time to form in that vessel. Also here that they've circled in red, little bit over here. Here's my hyoid. So always find what you know. Find the hyoid, find the epiglottis. We're going to get to thyroid cartilage in a few pictures here. Find what you know. All right? Carotid plaque likes to run. So there's that little diagram. The common carotid artery is then where it starts to gather. And that's here where we are, down in this corner here. All right. Can't find styloid. Hyoid is off. So if hyoid is off my image, for sure I'm not going to see any thyroid cartilage, right? Because you know anatomically how far below that is, right? I lightened this one purposely so that you could see the carotid plaque down here. The vessel is narrow and vertical. That's how it's going to fill the walls. As the walls start getting sticky, that's when the plaque starts gathering. Also very smiley here. What I wanted to show is normal styloid process. Here's the earlobe. That is a normal styloid process, a normal styloid process. They should be right around the earlobe, maybe a little bit past, maybe a little bit short of the round part of the earlobe. We all have two styloid process. That is normal. You are then looking for ossification from that styloid down to the cornu of the hyoid, to the bony attachment on the body of the hyoid. Yep, those pretty thick. And they start to look like twigs from the yard, don't they? And they even get a little segmented, kind of look like finger bones, like phalanx, right? But they can be, and yesterday, my group yesterday, it looked like a piece of bacon. It was so big. It was huge. Oh my gosh, huge. I have one from the book. It's as huge. But there's your stylohyoid ossification, right? So the ligament ossifies. Why those little bone cells want to grow on there, I do not know. This one came, so it already clicked here. This one came from your text, figure 3111, and that was yesterday. Same thing. This is all stylohyoid attaching then to the cornu on the body of the hyoid, and that's how big it was yesterday. Oh my, and huge, huge, huge. You know where they attach. You're finding that line. You can find them anywhere in the middle, starting at the origin, starting at the insertion, somewhere in between. You may see opacities in that path. Then you know it's that ligament. Otherwise, normal styloid, where the ligament has not grown in front of our eyes. Everybody good on normal versus ligament, okay? I like having everybody together so we can touch on all these things one time together here before you leave me. All right, tonsillolis, you know where your airspace is, and that's where you're going to find your palatine tonsils. So they can be small and maybe one or two on or off ramus, even towards the angle. This is quite a large cluster of tonsillolis here also, a little bit further towards the angle, but all in that airspace. And here, just kind of a few isolated. All right, tonsillolis. All right, here's our thyroid cartilage. So the laryngeal cartilage calcifications, I pulled this right off of your text. You can take a look. They are always incidental findings on a panoramic. The calcified tritious and thyroid cartilage are the most frequently seen, and we've gone through that. Tritious means a grain of wheat. It's what it looks like, kind of a piece of rice. The top 2 to 3 millimeters of a calcified thyroid cartilage, which is then called the cornu, there also, same word, is what we see. That's what becomes visible to us. But those differences in morphology and location enable the clinician to distinguish between those calcified cartilages and carotid plaque. That's the take-home message. That's why I hammer this so hard. Those of you going to programs, I know you will get to programs where other residents do not know this. They have not been taught this and how to separate away what is normal thyroid cartilage away from pathology and carotid plaque. And I have our students who then go away and email me back. I was the one who knew what that was, right? Because everybody doesn't teach it. I want you to be armed with as much knowledge as you can about this. Both of these came from your text. Here is your thyroid cartilage. Here's the hyoid up above. Thyroid cartilage. So this is the cornu, are those top extensions. This is what it looks like. So this is the tritious cartilage up on top. I don't often see the tritious, every once in a while, but this is normally what I'm seeing, is that portion, that cornu of the thyroid cartilage. And I have to be able to distinguish that from carotid plaque. Right? Thyroid cartilage, always continual from the bottom of the image, always. Carotid plaque may or may not be, depending on how much plaque has gathered. Right? Thyroid cartilage always has a stop. Right? It's always uniform. It has a border, always. Carotid plaque may or may not mimic that look, that shape. Okay, everybody good with that? You're going to be the ones who know when you get to your programs. What else? I've got epiglottis here, of course, arm of hyoid into body, out second arm. A little bit of calcification. I'm not sure what. Could it be tonsillolis? Maybe. Sometimes you'll just get little calcifications in the tissues for whatever reason. Styloid process, normal within the earlobe. Anybody else? Questions about anything else you see here? All right, here's osteoma cutis. I know many of you have not seen it on patients. You're only going to see it when you're in cheek area only, because this is all going to disappear when you have teeth. It's all going to blend away. All right, long-standing acne, so it is small and turning into bone again, hard areas inside the skin of the cheek. Here's your soft tissue covering the ridge, the maxillary ridge. So this is soft tissue here, but all these little guys here are those ossifications within the skin, osteoma cutis. How density and contrast either help or hinder, right? So we're always, I always pull you to look here. Sometimes when you lighten it, wow, there's the thyroid cartilage cornu right here. Here's my hyoid, arm and body, stylohyoid ligament, yes, coming all the way down, right? So sometimes just playing with contrast and density help you see some of those things a little bit better, right? Initial look at a panoramic, And again, we're going to come down here to this corner. So I'm going to lighten it a little bit for you. And again, way at the bottom, this is thyroid cartilage again. This is probably carotid plaque up here. And there's my hyoid, and here's my epiglottis. So we got all four there in one little corner. So on your test, I may give you a half, just the half of that panoramic. And just like the report says, carotid plaque, yes, on the right, yes, on the left, yes, bilateral, if I give you the whole thing, or no, not there. Yes? Okay, so one more time, this is the thyroid cartilage here, the corner of the thyroid cartilage. Here's one arm of the hyoid coming into the body, and then out the other arm. You know it's a U-shaped structure. And then here's my epiglottis right here. There's my soft tissue epiglottis right there. Okay? Right in here. This side, here's my epiglottis here. And then there's my hyoid. Good? Yes. Always below, right? Anatomically, thyroid cartilage is well below your hyoid. Carotid plaque can be running up and down the vessel because that carotid artery runs, right? But typically where I showed you the diagram of where the external separates, it's that common, and that's typically where it starts. That's when the physician's listening with the stethoscope. They're listening for that blood flow in that area, for that swooshing and whooshing around a particle in there. So typically that's where it's starting. So probably I would say 90% of the time in our small area where we're just seeing a little bit, it's usually above the hyoid. Usually. Not always, never say never, right? But usually. Everybody good? All right, here was another. This one has the implants up here. So again, we're looking down at that corner, and I think I lightened this one also for you. So down here again, here's my epiglottis. Oh, sorry, that's hyoid. It's really separated out. Arm of hyoid, body, arm. So you got to find your two arms there. And then this is my thyroid. Oh, this is a different one. This was a gentleman, and whether this is my thyroid cartilage or not, see, it's not continuous down off, but I've got a little bit what I think is carotid plaque here. Let me jump back real quick to that image. Yeah, and a little bit deceiving. So not quite sure if that is my thyroid cartilage or not there. Typically, they are all the way down and off your image there. But anatomy does crazy things sometimes. Okay. Maxillary sinus, mucus retention pseudocyst. Left is a slice of a cone beam sitting right on the floor of the sinus. And of course, here it is. So it does hold its shape, and it has that rounded appearance to it. Right? Mucus retention pseudocyst. Do you have to do anything with it? Nope. But I would be aware if you're looking to do implants on a person in that maxilla, of course you want sinus health before you start drilling holes up in there. So it may be worth sending your patient to primary or ENT, depending on what you're doing up there. This was, I had just seen this a month or so ago, incidental finding. That's that new Inspire, that if you've heard it, you've heard the commercials about it, that implantable for sleep apnea, and here it is. So this is what they implanted then in the muscles to keep somebody breathing, and here's its ghost. So this metal down here, then it ghosted and it pulled across. That's the ghost of this Inspire there in the throat. Somebody, maybe this is the second one. I think we're going to start seeing more and more of them on our patients. And you will also in your practices. Cone beam, you good on what view is this? Frontal or coronal? C is sagittal. And D is Axial, right? So axial, frontal, and sagittal. You will start to see more and more of those. A couple generalities here. Cysts are typically radiolucent. Cysts, fluid-filled, epithelial line, radiolucent. Can they have calcifications? Yes. Chronically, they can develop calcifications within cysts. But typically, a dentigerous cyst, radiolucent. Anything solid, benign tumors are typically solid. A tumor is solid, radiopaque, right? Radiopaque, osteoma, chondroma. Even when we see odontomas, that they have tooth parts in them, radiopaque parts inside there, right? But cysts, radiolucent. Malignancy tears through and eats through the bone, right? I've just got a few pictures. You tell me how long. We're going to go through quickly that. Remember, how do you write about a lesion? How do you describe? I'm going to simply go through them here. We localize it. We assess periphery shape. We analyze internally. We analyze what it's doing to other structures around it, and then we would formulate an interpretation. Okay, so localized, bilateral, unilateral, maxilla only, mandible only, periphery shape. Remember the words corticated, sclerotic, soft tissue border, scalloped border, unicystic, multilocular, all those words we used. Internally, lucent, mixed, opaque. Analyze the effects on surrounding structures. It can push teeth. It can eat bone, resorb bone. It can push the canal. It can perforate bone, so lesions that are very aggressive. It can perforate through the floor of a sinus and push teeth all the way up into the notch, the mandibular notch. So lesions can get kind of crazy and do things with other, eating away the lamina dura, eating teeth, but typically malignancies just push. Got to know your normal anatomy, knowledge of pathology, radiographic findings, signs and symptoms come from the patients. And I said, Dr. Gould's pretty smart, but you're smarter. Pearl AI might think she's pretty smart, but we're smarter. We're smarter. Got some pictures? Malignancy, right? Eating it up. Eating, taking away all the bone. It's that water on snow kind of just eats away at the edges. This is another malignancy that is pushing out. So that sun ray, those are some of those words, D3s for exam. Sun ray appearance here, that tumor in the bone here is pushing out. And periosteal reactions are some of those words you've learned. True occlusal there. Describe what we see. I gave you this in year 2, and now you can tell me tooth number 27, 28, T. So what's congenitally missing? 29. And I can say that with certainty because I still have that primary molar there. Right? Mental foramen. Oops, sorry. Sorry, people watching. Mental foramen, IAN. There's my canal. He's a little wide. Yep, we got caries, so that could be true pulpal. Or again, it's because that canal is laying down on top. Adds a little lucency to the look. What tells you cyst? Lucent. Where should a follicle be on an impacted tooth? About 1 millimeter from the crown, right? Once it starts spreading and enlarging, then we're going to start to get, they say about 5 millimeters out, you're starting to call it a cyst that's pushing the bone up, which is what's creating that border there. And all the way down off of my image here, dentigerous cyst. Tonsilloliths, lots of them too. Right? Portion of a pan, lots of them. Anybody know what it is? It is a cementoblastoma. What we saw it in year 2, what kind of border does it have? Soft tissue, that's what the black arrows are at, the soft tissue border of this solid cementoblastoma here. Not malignant, benign process, but can be aggressive and painful, right? Can't see the bottom of the root even because that cementoblastoma hanging on it. To find me, of course. Thanks for coming.